So MedTech Boston, over the last 3 months, has held this grand challenge to clinicians of how they would use Google Glass in the clinical setting. It was an open call to clinicians around the country, not only just for physicians, but anyone in the clinical setting, including nurses, physical therapists, and pharmacists, and everyone else. 50 plus contestants competed, and 13 were selected for the semifinalist round over the last 2 to 3 months. And now we have those finalists here, and they have flown in from around the country. So what's going to happen is we're going to have the 10 people here. They're going to have 5 minutes to give their presentation of how they would use Google Glass in the clinical setting. Then we're going to allow 2 minutes for questions from our illustrious judges and also the audience. And at the very end, the winners will be announced. That will be in about an hour. So we are going to start with Florence Dew.
All right, Florence. Okay. All right. Hi, everyone. My name is Florence Dew, or you can call me Flo. I'm here to present Foveor, an image handling app for Google Glass in the operating room. And Foveor comes from the word fovea and OR put together, if you guys are any eye specialists in here. So we are all guilty of being distracted on a daily basis. And this can be usually, just a normal distraction, but it can cause a lot of very dangerous issues. I went to Wellesley College and studied visual neuroscience, where I built an eye tracker and studied visual distraction. And this is something as simple as a web page where you look first, but where do surgeons look first? Here's something that is a normal operating room, but you can see that there are way too many monitors, and it takes the focus away from the patient. And here, again, you can see there are 6 screens with 6 different ideas of information, and it's all inside the operating room, and they have to focus on all those images. Here is Dr. Fahim, and he's a neurosurgeon, and you can see that he has to look off to the left while holding a probe perfectly still in the brain. And that takes a measure of skill and luck, and you don't necessarily want to have too much reliance on luck. Here again is the brain, and you can see, if you aren't a neurosurgeon, what kind of structures you have to avoid damaging, blood vessels and other areas. And here is another possible application. There's a 2D image of the eye, and here is a video of a 3D reconstruction of those slices that an ophthalmologist might want to use while he's operating on the eye. And again, just so you can see on the top, this is a macular pucker surgery where they go into the eyeball and they go straight to the back of it. And they need to operate on very delicate structures in the back of the eye, but they all have to do it while turning around 180 degrees to look at a different screen. You can see that there might be some complications with that. Every single time a surgeon looks away, there's the danger of decreased patient safety and also decreased efficiency, including medical error. So there's a need for safer and less distracted surgery. And so in Foveor, you can take images like a 3D reconstruction of the heart, MRI, fluorescence angiogram, and consolidate all of those and look at your patient. But the really cool thing is the possibility of using probes on that patient, because your patient is not straight up and down. You can use it to triangulate the patient, and as your patient is rotated, so are your images, and also to the right depth. You can also record and communicate for medical legal purposes, as you could see from the previous presenters. So you can say again, OK Glass calibrate, surface map, image register, OK Glass navigate, and triangulate that area of interest, and then swap, rotate, or zoom those images as needed. And here is, again, the ophthalmologist, a possible solution. Again, behind him is the fluorescence angiogram, and this is him looking at the patient. So what is he seeing? This is the patient, and if you're not an ophthalmologist, or even if you are, you have to look at particular areas in the eye and do some laser surgery. And there's a very beautiful angiogram that you can actually get, and those star-like areas are the damaged areas that you want to get rid of with your laser surgery. So what you should do is really know where those are, overlay them, and be able to perform the surgery right there with that image. So you can see he's doing that laser surgery. And ideally, you'd have that on the Google Glass. So you can also see potential applications in perhaps liver resections, or again, those brain tumors, having those 3D images right in front of you as you're operating. and how many surgeons and patients are truly affected by this issue. There's over 135,000 surgeons performing 51 million surgeries. You can kind of imagine the kind of impact it would have to not be distracted. There's a 14 to 47% increase in the aging population, so surgeries will have to increase. And how does that affect the OR? The equipment market is valued at $770 million in 2010, and it will grow up to almost $1 billion. And surgical navigation systems by themselves will grow up to $195 million by 2016. So with the demand of OR solutions expected to increase up to $3 billion by 2018, you can see that there's a need for less distracted surgeries because people do not want medical errors. They want to increase patient safety and patient outcomes. And here, just to recap, we did talk about distractions. We talked about those structures you needed to avoid. So if surgeons are less distracted, there will be an increase in patient safety and an increase in efficiency, and we can improve patient outcomes. And that was Foveor. And again, Foveor will be an app where you can consolidate all those images and perform excellent surgery and have great patient outcomes. Thanks to these people at Beaumont for helping me with my presentation, and thank you for listening.
Wait, hang on, Flo, don't go away. That was amazing. But I think we're going to have 2 minutes for questions from the judges, if you're up for it. Okay.
Great. And our keynote speakers have agreed to be our lovely judges. Again, we have Nayan Jain, Presidential Innovation Fellow. Please wave. Great. Chris Coburn, VP of Innovation at Partners Healthcare. Raphael Grossman, Karen Deep Singh, and Steve Horn. So we're going to actually open up to questions from them.
So have you looked at, and first of all, this is great idea. Being a surgeon, the inefficiency just makes you so mad. But have you looked at ergonomics, sort of some measure of ergonomics on this for the surgeon?
Okay, so first of all, I'm a first-year medical student, and second of all,
And keep asking questions then.
okay, but second of all, I read a lot of articles on this, and I actually visited a bunch of ORs and went to all sorts of departments to make sure that I had the full picture. And I do realize that Google Glass is not exactly the right angle for surgeons, but it's something like these are types of issues that are really how do I say this? There's engineering type issues that are solvable, and then there are big picture issues because you have a vision and you know this is going to work. If it works, and it'll be amazing. So as long as you can solve those engineering issues and get the right minds together to get that to work, I think the value in actually getting those images in front of the surgeon in an angle and in a way that he can appreciate, it would really change. It would change the landscape of surgery.
I was just going to say congratulations. I think it's an excellent idea. The only comment I would make is that augmented reality applications, having tried to build them on glass, I think the lag time is still too much, but I think the idea is spot on. And I think if the technology and the processor was there, this is fantastic and would have great clinical applications. So congratulations.
Thank you.
Just a quick comment. Great icon, by the way. Did you design that, or did you have?
Okay, so on the bottom right of the screen is my classmate Renee Holloway, and she was the one who designed the logo.
Nice.
Yeah.
Congrats.
So I agree. Really great idea. Augmented reality really has the potential to really transform healthcare. I think one little concern is much like Karen Deep's. How are you going to get augmented reality to work with glass? The parallax effect between the screen and the camera is can be quite large depending on how far you're away, and there's no rangefinder on the glass itself, so you don't really know how far you are. Do you envision putting some sort of registration marker to tell how far you are by size?
Right. This was something that was pioneered, I think, in neurosurgery especially, and they have those markers that they put on the patient to actually get to the right depth because I guess brain surgery and spine surgery especially too, they have to be very precise. So it's actually startling to me that wasn't translated into more fields. I know that there are some companies that have expanded onto that. And again, none of them though have really put it in front of you. And if you can get that so that you have decreased lag time and it's right in front of the surgeon, those technologies are readily available, and hopefully we can translate that into Google Glass.
So since you are in medical school, have you
Yes.
thought about the implementation? How does a surgeon 20 years into their career begin to use a device like this?
So, because I'm a first year medical student, I was very astonished actually when I went to talk to the people at the hospitals. My dean of my medical school went and contacted a lot of the chiefs of surgery departments inside the hospital, and all of them were right on board. As soon as they saw the potential, like this slide deck, they were saying, "We want to do this right now. What kind of funding do you need? What kind of people do you need?" And they could see the potential for them and their patients, and they are, chiefs of their department, so they're not the younger generation. And knowing that they would be on board, and hopefully perhaps more people being able to see this, I was hoping that more people in the audience, because you are physicians and have more experience than I do, if you could see the potential in this too, then that's the kind of buy-in that I'm looking for, and I would appreciate any feedback, especially on this idea.
Great. So I think we have time for 1 to 2 questions from the audience. If you want to ask a question from Florence, you can just stand up, introduce yourself. Great. Florence, you've answered everyone's questions.
Wow.
Thank you.
Thank you, everyone.
Thanks, Florence. And next up, we have Matthew Snyder. Matthew, you want to come up and introduce yourself really quick while I pull up your slide?
Hi, my name is Matt Snyder, and I'm going to do Google Glass dictation. Dr. Singh, please don't go too hard on the questions for me. So my idea came about by a personal experience with my physician. It was a very impersonal encounter. He was on the laptop, just writing down my symptoms. So this idea really stemmed from it. And while I was researching, I came across this one image that, again, just drove home the same point, that this pediatrician, liked it when his patients drew pictures for him. And this one really struck a nerve because he's sitting at his desk with his back towards the patient, and it was just a perfect depiction of what I was striving for with this. So he went on to say in this article that, with the new stimulus bill putting, so much money into these electronic medical records, what is really the true cost of technology? So hopefully my solution, will try to get at that. So leveraging, the dictation functionality that we heard about before, I really want to develop templates that patient information can just be directly uploaded to, and then have some sort of technology to get that information into real-time transfer up into the client's server or the client's network, and really eliminate the physician need to go back in and put that into their database. And benefits, obviously, physician transcription time minimized, and interaction time obviously is maximized. I mean, it's almost obvious. So let's say you have John Smith coming into your exam room. The vitals, and again, I'm not a physician, I'm a business school student, so I don't know all the the technicals here, but I know enough to know that the vitals are taken, and this can be uploaded right into, mind you, this is a custom template that can be designed, so all the vitals are put right into the template. And then John's complaining of cold symptoms, so he's got a sore throat, cough, trip. It's more annoying than anything, and it's been the length of symptoms have been going on for about a week. So I just noticed we have a little timer there. So simultaneously, kind of like an autosave feature, I like to say, everything will be. Oh, there's my animations. Everything will be pushed out, every 2 minutes, 5 minutes, 3 minutes, whatever the case may be, into John's medical record on the client server, therefore, decreasing the amount of time that the physician has to go in and save all the information. Users, initially I thought physicians, PAs, nurses, but as I started thinking about it, I did some time interning with PTs, and it was just a ton of paperwork. So I really see this being translational to other disciplines as well, PTs, OTs, dentists, and who knows, chiropractors, whatever the case may be. I think it really can be used across the board for all, medical disciplines. And my business side coming out, value proposition, selling this as a value-added service, saving time, increasing interaction. I think that's really the value proposition that we want to drive home. The payers for this will also be our key partners, so just people fed up with paperwork, individuals as well as private practices that want to invest into this, and organizations like we heard before, Beth Israel and Brigham. that have really already adopted glass, these are the organizations that you really want to target, because these are the people that have really invested the money in this technology, hoping that and really believing that it's going to work. And these are the people that you really want to target. And revenue stream, looking at some similar products out there, I think monthly subscriptions based on a number of licenses, is the way to go. But obviously, this is still, early stages. And with that, thank you. I'd just like to thank MedTech Boston, keynote speakers, Google, semifinalists, guests, and the sponsors. Thank you.
This is Karandeep. So my question is, it's a business question, and that's actually, how do you convince someone to adopt this technology when there is so much variation in the market in terms of electronic health records? Because there's no one electronic health record that kind of goes across from one institution to the next.
Yeah, I brought that up too. I'm in an entrepreneurship class right now, and my professor, I brought this idea or this same question up to him, and he said you really have to focus on whether it be one individual who can make a large impact elsewhere or an organization, and develop it for them, and then see if you can use that same template elsewhere, and see if you can get other people to buy into that template. It's not going to be, I know it's not going to be easy.
The only thing I would add is maybe you want to talk to Nyan afterwards, because Blue Button may help you with some of the uploading, downloading. So I think it's a fantastic idea, and you should definitely pursue it. But he'd be someone to talk to, because he can help with actually making this a reality.
Okay. Thank you.
So I would agree, it's a great idea, and I guess a concern, why doesn't a company like Nuance or some other frontline player just jump in? What's your unique hurdle here?
Next. I don't know. I think it's partly, just new technology. I think the early adopters have, gotten on board, and you see, the same bell-shaped curve with all technology. I just don't think the acceptance is there yet. And
Probably here. Maybe you can get them to hire you after graduate school.
I think it's, it's just like anything. You have to get people to start buying into it, and then, as validation comes, then, more users will come.
So being a practicing clinician, paperwork is certainly one of my least joys in life and in practice. And certainly anything that will reduce my time charting would make me happy. I guess my one question is, there's always been a struggle between gathering structured data and being able to free text and really have a lot more clinical expressiveness. And there have been a lot of clinicians who really don't like structured templates because it doesn't let you really express what you think about the patient. Yeah. It's really good for billing. It's really good about clicking all the boxes, but it doesn't always really represent what the clinician is thinking about the patient. And for some clinicians, that really is an important part about being a physician.
Yeah, I spoke to a couple physicians about this, and having some sort of template to input, let's say, there might be 5 choices that you can pick, but then having a comment box underneath where they can add in additional stuff that they want to. I also understand, I know that, it's a very regulated industry, and you want to, I guess, be careful what you say. So they said that it might not be a bad thing that, there might not be a comment box, but they have said the same thing, that, they want to put whatever they want to put in there also,
Just given the limitations of dictation software and the fact that there will be errors with what's translated, do you think there's a value in actually saving those recordings?
Yes, I do, initially, but allowing them, the autosave feature was more or less just to get it into the system, but also having the ability to go back and double check, what was actually transcribed, because we saw the transcription stuff here today. I think that's very big problem, but having the ability to go back and actually change stuff afterwards, I think that would be key as well.
Great. So we have time for questions from the audience. Could you stand up and give your name and.
My name's Aaron Lemon. I'm a current business student at Boston University School. I was curious if you considered partnering with an electronic medical record provider like Athena Health that actually has programs like More Disruption Please, which encourages entrepreneurs to create businesses.
I did. I started looking at companies. I'm not familiar with the whole the entire landscape, but yes, I did, because that would obviously if we could partner, and if we can provide their service or their templates into our glass, then that would be a plus. But then you also have to look at it where what's going to stop them from saying, okay, we're just going to cut you out and just develop it for glass and then just sell it on their own. So it's kind of like a double-edged sword in my opinion. But I have looked into it, yes.
Any other questions? Great.
My name is Steve Personnel. Part of my question is, if you want to do this while you're engaging with the patient, there are things that you would put in your notes that you don't want the patient to know. So how do you deal with it?
Good question. And that's something, not being a physician, I don't know. I don't know, what the patient access is to electronic, medical records. So that's something that I would have to, bring on a partner, from that aspect,
Great.
Thank you.
Thank you, Matthew Snyder.
Thank you very much, Matthew. And next, I want to call up Timothy. Hi, there you are. Timothy, if you want to take the microphone, introduce yourself. I'm going to cue up your slide.
Okay. So my name is Timothy Youngst. I'm an assistant professor at MCPHS University out in Worcester. I'm also a CHF clinical pharmacist for Transitions of Care, and I'm also an editor for iMedicalApps.com. So my presentation is more of an idea, and that's my pitch, is how can we use and bring Google Glass down into the patient's home? Last year, I wrote an article for iMedical Apps about how we could integrate Google Glass into basically medical care. One of my ideas was about using Google Glass for visiting nurses and for healthcare specialists that go to the patient's home to actually use it and integrate into the patient's care. A little bit more background with this. When I was a student in pharmacy school, I was involved in VNA, or Visiting Nurses Association. I was a volunteer. I did home hospice, home palliative care. My responsibilities were to help with medication reconciliation, pain management, and such. It was always a very difficult process trying to translate the information you saw for a patient in their home to the physician or to the care provider and get them to understand what you saw and how to treat them. That's a key issue here. And when you look at this, in 2007, it was estimated there's almost 1.5 million patients who are receiving VNA care a day. This number is going to jump extremely high due to the aging population that we're facing. And by 2050, it's estimated there will be 27 million people receiving long-term care. So let's start with the case. This is my grandmother. She recently had pneumonia, was in the hospital. She developed C. diff, hospitalized for another 2 weeks in the ICU, went to rehab, and then, you know what? They get diagnosed her with early onset dementia. This patient went home. My grandmother went home. And she has a lot of barriers. She is a survivor of the Khmer Rouge. She is a refugee to this country. She does not speak English. She has multiple providers all over the East Coast where she has traveled. Distance is an issue for her. Ambulation is an issue for her, getting around. Making travel arrangements is very difficult because there's really no one to take her to the clinician to see. Most of my family are factory workers. They can't really take her. So when it comes down to it, there's multiple logistical barriers for patients that are in the VNA care. That's the value, is having someone go out to help them and take care of them. But it's that connection then between the VNA and to the physician. And sometimes a telephone call does not cut it. So coming back to what you said, Dr. Rossman, telemedicine. Google Glass could be very valuable in this situation. Most assessments are hands-off. The nurse could be in a room in the patient's house and actually just record or transmit to the physician in their office what they saw, what's going on, how is this patient doing today? That's key, and that's really pertinent here because even if the physician asks them to do something, maybe just a little bit of assessment, it can be done, and they can see it from firsthand experience and see what's being communicated. The other thing is, does anyone recognize these translation phones? To me, they're a bane. But you have a person talking on the other line with you. They can't see the patient. The patient brings in a piece of paper that they wrote in their own language that you can't read and that they can't see. Take Google Glass in a home with a patient. Take it with my grandmother. You can have the translator see her emotions, her frustration, as the communication goes along, if it's there. You know, in addition, if there is anything there that can be read, the translator can see it. The implications for this is really huge. You can have a huge outreach for patients that would have to be drawn in, or you have to get a translator to go to a home. This telemedicine purpose can really be expanded to a lot more diverse population. The other thing is that we can use Google Glass to record a lot of interactions with our patients. This could be uploaded into the EHR. Imagine you're a physical therapist. Your patient, you go home, you see ambulation, their knee movement post a knee replacement is only so much. You go back a few more days, you see the ambulations increasing. This could be uploaded, and a clinician could see it, and it could assess and say the patient's on track. They're doing well. This is documented and shown. No one needs to come in, and they don't need to bring the patient in. You don't have to worry about these visits. You can actually monitor and record it. Google Glass for me, as a pharmacist, where I see is very interesting is when I go to a patient's home and seeing a patient, you learn a lot about them. This is my grandmother's medications, just along with everything else. And you know, when I went home to go see her, there's things that aren't on the EHR. That aren't on her medical record. There's things that she's taking. This stuff could be documented and shown. And that's really a big thing here. And Google Glass could really help with the medication reconciliation problem, which is huge because there's so many errors happening right now, so many people suffering from this. And lastly, I'm not going to beat this. We've been talking about this stuff could all be uploaded into the EHR and used and reviewed. So different functions would be documentation. You could use it for wound care assessment, communication such as translation, telemedicine such as a virtual doctor visit, and then mobile references as you go along. When it comes right down to it, Medicare payments just for Medicare alone has risen for home health care from $8.5 to $16.9 billion. We're seeing a huge increase. And the number of agencies out there is huge. It's probably right now more than doubled since last time. Home health care agencies are very interested in this as well. So in the end, we can use Google Glass to keep people out of the hospital. Thank you.
Judges, if you could just give us your name before you speak, because the audience cannot see you.
Congratulations, I'm Rafael Grossman. So you obviously covered a lot of ground, and all your ideas are fabulous. I think that what I most praise about your take is that you're seeing Google Glass on the patient side. And I was talking to Naya, and I think that, you know, we all obviously were providers, and we sometimes think on our side, but I think that Google Glass and wearable devices are really an incredible tool on the other side for patients to access their records, to record their information and integrate. Again, it's about the flow of data. I think that once we change that flow, and a wearable device like Google can do it, and think of this, this is just the first version. Imagine what the next version, imagine what artificial intelligence and deep learning systems are going to do with voice recognition, you'll be just talking, and IBM Watson, like, think about that, is going to be translating no matter what accent do you have. So it's going to, but I think that patient's perspective is really a winner, and going from that angle, I think it's really something to praise.
I think in the end, technology needs to be an adjunctive tool to no matter what we do as a clinician. Patient is always the focus. The minute we lose sight of that and use technology as a medium to fulfill our goal, why not replace us with computers? It's that human element that we really need to treasure. When you go into a patient's home and you work with them, it's touching. You see their family, you see their animals, you see them. And that means a lot. And I think just to show someone in their natural environment how they live, really translating it back through this service would be as a great medium to help you as a clinician to understand how is your patient doing. I mean, in an office, how often do you see them? A few minutes?
So, Chris Coburn, Tim, terrific, compelling presentation, and I agree with Raphael. What I like about it is it kind of falls outside the sphere of what is occurring, in the provider world. And I think from a practical standpoint, you think of decision makers in a provider environment where a torrent of new technologies are coming at them every week. I think the uptake is probably more likely to occur first in this kind of setting. So really great, and a nice job discerning that. The other thing I would say, I don't know if you've looked at Health Excel or any Rock Health, we're involved with Health Excel. They might be a great match for you, and if you're not familiar, I'd be happy to link you with them.
I would be happy about it.
Just a quick comment again. Congratulations on the position here. But you mentioned quite a few different use cases. So if you had to pick one, what would it be, and why?
Probably for me, biggest thing would be this idea of a translational service, and this comes back just from personal experience. You know, when we teach students in school how to work with a translator, the whole thing is I'm talking with you, right? I'm not talking to the third party to translate for me. For the idea that I could keep eye contact with you and the communication still going on no matter what, being fed back to you, you get that relationship going. And the other thing for me, there's so many frustrations that occur in a translation scenario where you can't read that body language when you're on a phone. You don't know how the patient's reacting, and you need to take a time out and maybe talk about. And also writing things. I've had patients bring things in like, you know, Mandarin Chinese. I don't have a translator there to come see it. I don't know their medications. I can't reconcile it. That's difficult for me. And I think that's like the big thing for me is right now I see this as a tool for that such a service.
Steve Horn, really great presentation, and I think the theme is really in line with our current healthcare system and keeping patients at home and away from the hospitals. I guess my question is, with these translation services, glass is really kind of a one-way device, right? You can see it, but the patient can't see it, and the patient can't hear the translator. And translation is really a two-way thing. So if the patient can't hear the translator and they can't see the translator, how are you going to deal with that?
So my idea was if you can actually type, I mean, a lot of us carry this kind of medium, right? Some of us nurses that go in VNA care currently bring along an iPad with them. There's no certain reason why you can't invite the person into the room with them just to see it and experience it as well, or they could see them talking if you need that there. And also from that person talking over the smart device, they can hear it audibly as well. It's not just you. I envision it as Google Glass as a standalone could help, but I think just for that participation, that's where it would come into being. Whether that's even using off a computer and using a Google Hangout and you can hear it coming out. That's where I see like how that would shine through.
Okay, we just have to move it along, so we're not going to take any further questions. Thank you, Timothy Angst.
Thanks, Timothy. And let's see, up next we have Todd Thelman. Now, the Google Glass Challenge actually ran several rounds. So we had a few rounds, and Todd, who's right behind me, won 2 of the rounds. Was it the first and second round?
Second and third.
Second and third round. So he has 2 presentations to show you today, 2 winning ideas. Take it away.
Thanks. So my name's Todd. I'm a 5th-year resident in the Harvard Plastic Surgery program. When I'm done with my training here, I'm actually currently applying in hand and microsurgery fellowships, so that's my overall career trajectory. So both these ideas are born out of experiences I've had and frustrations I've had progressing through residency and ways we could potentially make those better using Google Glass. So what you're seeing in the top left is a map of the United States 2011, and these are surgical specialists per 100,000 population. So the darker the green, the more surgeons there are. So what you see is a concentration here in the Northeast. Actually in Boston, we have the most anywhere in the world per capita, and lots of areas of the US where people are relatively underserved. At the bottom right, the little dots on the US map are the level 1 trauma centers. Again, we have 4 of them here in Boston, and huge swaths of the US without any access to these at all. Actually, 80% of the US landmass has no access to a level 1 trauma center. So these are 2 recent papers from the hand literature, both of which essentially get at the disparity and the disconnect between availability of surgical specialists and the need that patients have. What I see when I take a hand and face trauma call at our hospitals is that I see lots of patients transferred in because there's a relative unfamiliarity with hand and facial trauma, but yet my personal experience as well as the experience in the literature is that the vast majority of these patients don't actually need to be transferred, both at great distances and great costs, both to themselves personally as well as to the healthcare setting. So the question is, how can we leverage Google Glass to make that experience better, both for the physicians as well as for the patients? So my notion is expert on call. So you deploy Google Glass at the front end in the tertiary care setting with the specialists as well as out in resource poor settings. That allows physicians, physician assistants, emergency room doctors, whoever's seeing a patient with potential need, to essentially call up a physician at a tertiary care center, do an exam in concert with them, and if they don't require transfer up to a tertiary care facility, the care can be arranged remotely, or they could be sent back, to a local provider for further follow-up care. So who benefits? Essentially everyone. Patients in the resource-poor settings, physicians in resource-poor settings benefit by having improved access without necessarily improved cost. Hospital systems, physicians can improve their reach out into the community. We're in an era where large health systems, insurance companies are trying to improve their reach and improve their catchment areas, ACOs, things like this. This is a way to further cement that relationship and actually bring them into the hospital system without necessarily moving them into your hospital system. The other follow-on notion of this is within training programs, you have junior residents who are primarily in the hospital taking overnight call. You have nurses who, occasionally are dealing with complex patients. They've had complex surgery. Children's Hospital, I see kids all the time who have surgeries that very few people outside of the truly elite surgeons really understand. And questions come up 24 hours a day. Surgery is not something that lends itself to a 9-to-5 job. And so the question is, we have these calls in the middle of the night, and it's very difficult for the senior residents, chief residents, sort of on my end, to really understand what's going on at the hospital without going in there directly. So, you could leverage Google Glass within academic, medical, and surgical training programs, so that senior physicians or chief residents at home could be, sort of there with you at the bedside in the middle of the night or in off hours to try to help you through these difficult problems. Lastly, just to get at the business model, this isn't my forte, but sort of two basic models or three basic models. One is in areas that have large hospital networks that sort of own or command large geographic areas. They would probably license their own systems and distribute the units directly. In fragmented areas that don't have a dominant insurance provider, don't have a dominant healthcare system, you'd probably target specialty physician groups who would sort of have an onus to increase their reach within their region. Lastly, large academic medical centers, with this drive to reduce errors, reduce cost, could be buyers. And then, should this be successful, you could imagine, the WHO, Gates Foundation, wanting to deploy this in developing countries where trauma is a massive problem and all the access issues are even larger than they are here. So I think for that one, that is it. Questions?
Sorry to be first, but Rafael Grossman, telemedicine again is one of my passions, and I see exactly what you're saying, and well, I have so many things to say that I won't have enough time. I hope we can catch up later, but I think again, Google is the natural evolution. Google Glass, the natural evolution of the platform. Telemedicine. I'm in Maine. At one particular point, we have one trauma surgeon on call for an area that is larger than the area of Massachusetts, Vermont, and New Hampshire together. One surgeon for the whole area. Obviously, the number of patients, Maine itself only has 1.2 million people, but the geographic area is gigantic. One thing that it's sort of a barrier to the beautiful sort of theory that you're seeing is at least within the U.S. Licensing is a big issue. So licensing, even within a state, privileging in different hospitals is just such a nightmare problem that we all probably have it. In Maine, we're pretty progressive and pretty sort of forward thinking in this regard. We have in a way smooth out our process of privileging, but still we compete with another health system in Maine, in the southern part of Maine, and it's tough. Out of state, it's impossible to do it. Legally at least, it is impossible. Now, when you go to another country, then that's different. I think that telemedicine through a device like Glass to telementor or to even treat patients or advise patients in other countries, it's certainly absolutely a plus. And the other thing in regards to business model, many states in the country, almost 30 or 35 states in the U.S. now, the billing for telemedicine is just as it is for physical medicine. As long as you meet the criteria, then you can bill the same. So it really has to be no different than the regular business of trying to get more patients.
Yeah, agreed. There definitely are massive regulatory challenges, but I'll say, we're already wrestling with them. I virtually every night I'm on call, I get a call from Vermont, New Hampshire, Maine, and areas of upstate New York, typically with pediatric hand injuries, where sort of no one wants to put their neck out and say anything. And it's relatively rare. I mean, we transfer them into children's commonly, but a lot of these things are pretty minor. And there's really no way for me to document this. They don't have a children's hospital medical record number. I never get a chance to actually examine them. But I guarantee you, on the other end, my name's being recorded in the chart, and spoke to, pediatric hand surgeon at Children's Hospital, and all this. So, a lot of us are already existing in this legal gray area. And I agree, the regulations absolutely need to catch up, and I'm hoping that they will, which should, yeah.
So, Chris Coburn, my former employer, Cleveland Clinic, had implemented a national e-radiology program in about 20 states, and licensure is a huge issue, as both you pointed out. I guess my question is, in your conception of this model, how are you leveraging the mobility of the glass? Because if it's, if you're bringing the patients to some kind of locus, some center in this remote geography, what's the advantage of having it worn on the body versus just having it as a fixed capability?
I think you really just need it on one end or the other. You can have one unit in a in a health center remotely. You have one unit sitting in an ER remotely that could be used, or similarly specialists in town could be users or not.
But like telestroke's become relatively popular. I think here in New England as well. That's a fixed console. Again, I think for your sake, you'd want to be able to take advantage of the portability of Google Glass versus some kind of installed mechanism, because then you're not discriminating between what's already out there. At least my perception.
If I can add to that.
We would love for you to add for that, Raphael, but we are behind on time. Thank you, Todd. We are actually going to hear your next presentation, if that's okay.
Sure. Okay. So my other idea, and this is very similar to what Matt presented. I'll try to just sort of skip past the things that he already went into with his documentation system, and sort of highlight what innovative elements I want to present. So I really like the clinical practice of medicine. I really love seeing patients, and I really love operating on people. I really hate writing notes, and any clinician in the room can absolutely identify with this. So note writing it's tedious, it's time intensive, nobody likes it. At top left, I'll admit, I don't know that guy. I took that photo from the internet and little credits there. At bottom right, I swear to God, this is not a posed photo. That's my junior resident, Paul. This is us in our little hovel dungeon at the Brigham, and he's writing a note because he's our consult resident. So, unfortunately, note writing, it's an afterthought, it's low value. Clinicians are not incentivized to craft thorough, readable notes. The current state stinks. People have already talked about structured, standardized notes where you are relegated to box checking, clicking things off, and it results in this muddle of almost random facts. It's not fluent, it's not readable, and there's no way to nuance it to really show what your thinking is, as Dr. Horn pointed out before. Dictation's a little bit better, but it suffers from recall bias. Typically, physicians are dictating at the end of the day, at the end of a shift, at the end of a full clinic day, at the end of a 8, 10, 12-hour procedure. And furthermore, these dictated notes have to be actually typed out by someone, so they're not real time. They're not available to other providers for typically 24 plus hours, and that can be a problem. So what would an ideal note be? It would be real-time. It would be securely integrated with an EMR, as people pointed out before. Be written without disrupting the encounter, again, as multiple people have pointed out. Be fluent, readable. It should incorporate image and video as needed, and it should require minimal provider input. The idea is, on this case, I think we can leverage both dictation technology as well as natural language processing, and I think that that's an area where the technology is rapidly developing, and that's really where the innovation here is. So medical encounters are structured. We all take histories and do physical exams in a structured manner. There's a course in every medical school on how to do this. And so the idea is, so you dictate and you get a translation of everything that's just occurred in a history and physical exam. And then you run it through a natural language processing algorithm. And I will freely admit that they probably are not there yet, but they will be. And the idea is, so the algorithm is going to scrub the language, and it's going to populate a note in the relevant sections that a physician would take, and it would put it all together into a note. Areas that are not necessarily amenable to this are going to have to be dictated. As you go through your exam, the extraocular movements are full, the chest is cleared, auscultation. You may have to do some element of this until we find something better. But there are additional synergies. Photo and video can be embedded during a neurologic exam. You can really show what you're doing. You could videotape the consent process instead of making a patient actually sign a document. And so the benefits are you have a real-time, fluent, accurate, detailed, nuanced note that's done behind you without disrupting the patient interaction. This is enormous time savings at the end of a clinic day when I'll see 30 hand patients in clinic, in half a day, and then spend the next 2 hours just writing all my notes. You can imagine a next generation where quality assurance things are provided to you, within your screen if you forget to do them. So let's say you're seeing a primary care patient and you forgot to ask them about their weight reduction, their blood sugar control, their smoking cessation. Eventually these are all going to be regulatory requirements that the government is looking for you to document every time they come in. Did you do your EMR, your medication reconciliation? If the algorithm picks up that you never did that, it's going to flash it to you and say, okay, you need to ask these questions. So better quality assurance. You can imagine automated billing after this. And then same thing, if you're discussing a new diagnosis with a patient that doesn't already appear in their EMR, you could imagine point of care decision support, medication suggestions for lab tests, et cetera. And then you can imagine, this changing the medical legal landscape that, if you really could videotape encounters and whatnot, perhaps no more need for chaperones. You could free your nurses up to do more valuable tasks that, they necessarily don't want to do. So again, we can get into the business model more. I see I'm sort of running low on time. So again, it's my junior resident, Paul, on the left, and actually my chief resident, Frank, on the right. The idea is that's the before and after in my grand vision. So questions?
Are there any questions from the audience?
Steve Horn. Natural language processing and concept detection is a real area of interest of mine, and it's a research focus, and so really exciting stuff. There are a couple of other startups that are kind of in this arena on doing dictation, Augmetics being the one that comes to mind. How is this different than Augmetics?
I have no idea. It's not an area of business startup that I'm super familiar with, but it is something I'm interested in, and whether they need additional expertise or I have an idea that perhaps is an add-on or better idea, I really don't know.
So Nye and Jane, you mentioned the value of processing an individual note, but what do you think you can do with the aggregate of the data? Essentially having access to all the notes. What insights do you think you could find?
I'm not sure I'm understanding your question perfectly, but I think it's that if you had their entire medical record, what could you mine from it to
sort of looking at the population health problem, saying, you have access to multiple notes across a subset of the population. What could you determine from that? And is there a value in sort of building that into your business model?
I mean, I can imagine research questions. I'll admit I haven't thought about it as an add-on for this.
So this is Karandeep. I think, as you pointed out, auto-summarization has been a real challenge in natural language processing. Even recording a whole encounter, figuring out what's the doctor saying, what's the patient saying, has been a tough area. I would challenge you to actually talk to I2B2, which holds an annual NLP challenge, and they're based, I think, out of Children's Hospital. So I would actually ask you to talk to them, because this would be a fantastic idea for an I2B2 NLP challenge to actually help bring people together to actually build some of the technology to get at this kind of ability. Because once you have this, plugging glass into it is going to be hopefully a piece of cake. Thank you.
Thank you, Todd.
Okay, thank you, Todd. Next, we have Andrew Gonzalez. Andrew, thank you very much. Do you want to introduce yourself?
Sure. Good afternoon, or evening, actually. My name's Andrew Gonzalez, and I'm a general surgery resident from the University of Illinois at Chicago. I'm at University of Michigan now doing health services research. So I'd like to thank Boston MedTech for inviting us out here. My idea is to use Google Glass to streamline the triage of acute stroke patients. So you may initially ask, why is some surgeon up here talking about strokes? So the reason is because as far as a burden of disease perspective, strokes are a huge problem. They affect 800,000 Americans per year. They're the 4th leading cause of death, and they're a major source of chronic and acute disability. So to put these numbers in perspective, that means roughly every 40 seconds an American has a stroke, every 4 minutes an American dies of a stroke, and it costs our nation $74 billion per year. So how can Google Glass improve stroke care? Well, in understanding how you take care of strokes, you need to basically recognize that the first thing is you have to appropriately make the diagnosis. There's a number of things that mimic strokes, and we want to rule these out. Secondly, we need to subclassify the strokes as being either ischemic or hemorrhagic. The main reason being that if you give a thrombolytic such as TPA, they're the treatment of choice for ischemic strokes, but they'll actually make the bleeding in your brain worse for hemorrhagic strokes. And then finally, there's some time criteria that you need to consider, namely giving TPA within 1 hour, and you have to keep in mind your overall time window, which is, unlike many conditions, measured from the time the patient first had symptoms, not from when they showed up to the hospital. So this is sort of relating to the idea we've heard about pushing the delivery of care out into the community as opposed to once the patient actually shows up to your hospital. So what's my idea? Basically, I want to optimize the time in the ambulance. So normally what happens is somebody reports, grandma's arm is weak and now her speech is slurred. They call 911. It takes 20 minutes for the ambulance to arrive, another 10 minutes to hook up to the monitors, get them on the bus. And before you even reach the hospital, on average, you're looking at like 40 minutes. So a lot of that time is wasted because once the patient's on the ambulance, there's a lot of driving time. So what could we do to optimize care by using that time interval? Well, if you use telepresence technology, you can basically have the physician who would be the treating physician at the emergency medicine department do a brief history and an NIH stroke scale while the patient is on the bus on the way to the emergency department. So this would optimize in-hospital delays because essentially you'd be able to have the patient go straight from the ambulance bay right to the CT scanner if they're an appropriate candidate for TPA. So why is delay bad? Because for every minute of ischemic time, the brain loses 2 million neurons. I don't know about you guys, but I don't have a lot of neurons to lose. So doing a quick back of the envelope calculation, who is the potential beneficiaries of these? So assuming we have the 800,000 stroke patients per year, 80% of which are ischemic, 70% of whom do not get TPA within 1 hour, we're looking at about 500,000 people per year. From a business perspective, of course, it's at least 1 million people per year because you don't know somebody's having a stroke while they're in the ambulance, so we would have to screen all of these people. So as far as my business plan, I kind of don't have a lot of expertise in this, but I envision a sort of 3-phase rollout. The first would be a proof of concept in real-world patients to make sure that the technology, specifically the resolution, is good enough to pick up physical exam findings as well as resilience of the network. And of course, we have all of the HIPAA issues and data transfer issues to make sure that we're fully compliant from a regulatory standpoint. If you were using a lab in order to figure out whether or not it is good enough, from a strictly clinical standpoint, you'd want to look at post-stroke patients because in rehab, they often do maneuvers that are roughly similar to a stroke scale, and you can record all of these and have other clinicians look at them and see were they able to notice any deficits, improvements, or worsening of symptoms. The second phase would be to train and certify hospitals in the use of this technology as telepresence. Obviously, you don't want to just say, oh, this seems like a good idea, and everybody kind of adopts it willy-nilly. There needs to be some quality control. And the third phase would be quality improvement efforts through a collaborative, which are very popular, especially in surgery. For instance, the American College of Surgeons National Surgical Quality Improvement Project, and they basically use a fee-based subscription model in order to generate revenue. So who's going to pay? Obviously, hospitals and health systems have an incentive to adopt technologies that improve the care of their patients. A lot of this may be passed through to insurance companies, especially with new changes in the ACA that basically prevent the ability to transfer high-risk patients to other care. Now insurance companies are responsible for a lot more care without the ability to essentially dump those patients. And of course, Medicare, because 75% of strokes occur in patients over 65. So they're already on tap for the acute episode of care as well as rehab. So in conclusion, Google Glass may offer the opportunity as a wearable, hands-free, real-time video conferencing technology to improve the care for strokes. I'd be happy to take any questions.
Hi, great presentation. This is Karandeep. I want to ask you a clarifying question. So who do you envision is actually going to be the one using glass? Is it going to be the EMT and the ER doctor and everyone along the chain?
So what I envision is having a hangout. So once they get the patient on the ambulance, the EMT will be wearing Google Glass. And they'll essentially, from the ambulance call center, know which hospital they're going to. Then they'll initiate a Google Hangout. So at that point, essentially a stroke protocol would be called. So the emergency doctor would be there, the neurologist would be there, and they would basically pick up the line and they would have a conference call essentially.
I want to check out Triage, which is a startup company in Boston who's doing something similar, but I think it'd be something that very complementary to what you're trying to do.
Awesome, thank you.
Steve Horn, really great idea. As a first line kind of responder, being an emergency physician and receiving these patients, and being the person that's blamed when we don't make the 3-hour, 4.5-hour window, saving any minute is certainly great. I guess my question is, Boston EMS and most other EMS companies have Wi-Fi in their trucks, and so technology like this is certainly enabled now. Why is this better than simply mounting a high-definition webcam on the ambulance? The patient is almost always in the same exact spot on the stretcher. How is this better than just a webcam?
That's an excellent question. So there's two reasons why that's better. I mean, being in Boston, and I myself are from Chicago, yes, we have market competition has kind of increased technology utilization there. But having moved to Michigan, I can definitely say, at least in my experience, there's wide variability across the country as far as this goes. Two, although from an individual standpoint, Google Glass is a relatively expensive technology, from a systems perspective, it's relatively cheap. And as I understand it, mounting systems for HD cameras and all are significantly more expensive than $1,500 for a glass. Secondly, depending on the maneuvers, depending on the ambulance configuration, you want the ability to see what the person performing the task for the exam are. So in this case, it'd be, point to the frog, and they either point to it or not. Whereas if you have it in a fixed position, that may not necessarily meet the logistic needs for all ambulances.
Okay, thank you, Andrew.
Thanks, Andrew. And next up, we have Lilith. Thank you, Lilith. Do you have your slides queued up on a separate deck or on here?
They're on there.
Yeah. That's you? Yep. Okay. And you remember how to get the video?
Yes.
Okay, great.
Hi, my name is Lilith Sargasan, and I'm a pulmonary critical care fellow from Houston, Texas. The year is 1954. You see my grandfather Ernest, a young internist in a small town in Armenia, and he happens to be the only physician in the town. On a cold winter night, he's called to the bedside of a patient with acute abdominal pain. He quickly diagnoses acute appendicitis, and the treatment is clear. The young man needs surgery. He begins to arrange a transfer to a different city where surgeons are. However, of course, all roads are snowed in, and the transfer is impossible. So if you believe it or not, he manages to gather all equipment necessary and performs an emergent appendectomy on the young man, thus saving his life. However, he would not have been able to do this if he did not have remote guidance over the phone from surgeons from the other city. 60 years later, many technologies have come forth that have truly changed medical triage and management decisions. One of those technologies that I want to focus on is ultrasound imaging. First of all, I want to tell you why ultrasound is so special. First of all, it is highly versatile and reliable in diagnosing hundreds of medical conditions. In addition, the dynamic views that we're able to immediately acquire are amenable to immediate interpretation by the expert. Also, it is portable, relatively inexpensive, safe, and we can place it virtually anywhere. But I'm not here to talk about putting ultrasound machines across the world. I'm here to talk about bringing ultrasound expertise to anywhere in the world. Remote Guide is a Google Glass-powered application that solves the problem of lack of ultrasound expertise anywhere in the world. There are many isolated parts of the world where an ultrasound expert cannot be at the bedside by the patient in time of need. And some of those locations include the International Space Station, remote locations in Antarctica, outposts in a variety of other places. You can even think of cruise ships, transoceanic flights, and even our own hospital systems where an ultrasound expert cannot be in those ICU rooms where critical care fellows are doing bedside ultrasound. Although I believe we can use remote guide in many locations, I'm going to focus on the ISS as my model. And the reason is that NASA has had a remote ultrasound guidance system in place for a number of years. So when a medical emergency arises on the ISS, an ultrasound expert is called to mission control for once they can do a guidance session with a remote operator in space. Normally, the participants connect over a voice link, as represented by my telephone. Also, the ultrasound feed from the remote operator is transmitted down to Earth for the guide to use as a coaching technique. And lastly, there's a stationary camera placed on the ISS that records the remote scene for the guide to look at. Now, there's two main issues with this scenario. Number one is the problem of visibility and instruction. The ultrasound guide cannot really see what that operator is doing with the probe, and also the guide only has her own voice to use to guide the coaching. There's no ability to give visual information. So remote guide
It's right. Is it gone? Oh, go ahead and keep going.
Okay, Remote Guide is a Google Class-powered application that actually addresses both of those problems through the 3 usage modes I've come up with. Usage mode number 1 is a library of guidance modules that can reside on a local computer, and I can put on my glass and say, okay, glass, please bring up a guidance module of lower extremity for suspected fracture. And on the head-up display of my glass, on the left side, I can see the correct probe placement and manipulation, and on the right side, the target images that I'm expected to obtain.
Can everyone see that?
Such as that video. Usage mode number 2 expands on that, but the guide is wearing glass and is able to transmit a picture of himself doing a scan on a live human, as well as his own ultrasound feed to the operator for help. And usage mode number 3 is actually the most exciting, and it can leverage augmented reality to allow the guide to insert his own hand holding a probe into the field of view of the operator, therefore showing exactly the right scanning technique. And this is the next best thing to being at the bedside with the patient, able to grab the probe from that operator and show him what to do. So we don't have to finish the video. It just scrolls down the leg. 60 years ago, my grandfather was able to perform a non-surgical person was able to perform a successful emergent appendectomy with the help of remote guidance over the phone. Yes.
Great.
Today, astronauts in NASA perform diagnostic as well as scientific research successfully with vocal cues from mission control. And in the future, I believe remote guide can truly change and have an impact on patient care and research, because anywhere we can place an ultrasound machine in the world, we can provide virtual presence of ultrasound experts at the bedside. Thank you for your attention. I welcome your feedback.
So the flip side of NASA, this is Chris. Flip side of NASA, have you thought about defense application, battlefield?
I haven't.
Might be something
Now
like
I will
that.
think about it.
All right.
So just out of curiosity, what's the Wi-Fi like on the International Space Station?
There's a delay. There's Wi-Fi, and setting down the images, there's a 2 to 3 second delay in voice as well as the image transmission. It's not a huge deal.
Thank you, Lilith.
All right, next we have Malik, and I'm going to let you introduce yourself.
Sure. So hi, my name is Malik Majmudar. I'm a clinical cardiologist at Mass General Hospital and also the Associate Director of the Healthcare Transformation Lab, which is a relatively new innovation initiative at Mass General.
Malik, did you have a deck?
Yeah, it should be right after that one, I guess. Yep, that's it.
And you didn't have any animations or anything?
I do one, but we'll skip it
Okay,
for now.
sounds good. Thanks.
Yep. So, I was telling these guys, over the last 4 years, I've sent a number of patients to cardiac surgery, specifically valve surgery. And one of the things that always bothered me is, like, as a clinician, and I'm sure patients and families feel the same way, it's really frustrating when you can't actually see what the surgeon did or what the pathology looked like in the operating room itself, right? Because you spend thousands of dollars doing imaging tests ahead of time, trying to figure out exactly what the right pathology is, what the right timing is for the surgery, and then the patient comes out and you get this kind of long dictation, which is an op report. It's really not that meaningful. So the idea behind Scribe, it's a real-time Google Glass-enabled kind of visual dictation system. So if you look at the left-hand side of your screen, the typical op report is something like that, which is all prose. And it's about 3 or 4 pages long. And the problem is, op reports are really not usually complete in a timely manner always. And they don't contain adequate details of the surgery, and they're definitely not individualized. If you look at the same type of surgery, they kind of sound 90% similar from case to case, so you really don't know exactly if your patient was a unique patient or what exactly happened in the OR. And as you can see there, they're relatively antiquated, right? It's all prose. And furthermore, the more important thing is that they actually don't provide any educational value to both patients, family members, and specifically students in training. And in this environment, given the workout restrictions, if you can imagine, students in training are spending less and less time in the OR, and the number of cases they see over their time span of training is minimal, so you can actually lose out. Sometimes you actually don't even say a specific case. You don't get a caseload. So the purpose, as I see it currently, is really to document the details of the procedure, mostly for medical legal purposes and for billing purposes. And I think that's a very narrow view of the op report, and I think it potentially provides a lot more value than that. So the solution I'm proposing is this idea of a Google Glass-enabled system where it's a real-time dictation. It's a structured op note, right? So we actually built this already. So it's about, we use smart phrases. So if you say specifically pre-op diagnosis, surgeon, estimated blood loss, it kind of does your note exactly in that order instantly. It uploads to the EMR. A number of people have talked about that. It's easy to do. It's ideal for a future where procedure logs and notes don't have to be this antiquated, boring prose, but really could be live notes, as audio and video recordings that have significant value in it. If you look about complications, currently, most hospitals have this system called M&M, right? Morbidity and mortality conferences. Really, if you look at the conferences, it really ends up being, what did you do in the OR? What happened? It's a hearsay. There's really nothing to look at or review that's really meaningful. You can imagine if you have a library, educational library of these cases, you can go back to them, review them over time in a closed door setting and really have a very highly valuable educational session. So the idea there, what we build is, I won't go through the whole chart here. There are a couple of key features here, right? So the first thing you do when you start is you just say Scribe, which activates the actual app. You tap it once for the new surgery, so it starts a new op note. And the rest of it is just all audio-based, right? So it's just smart phrases. And what happens, it turns itself off once it hears a 2-second pause. So it saves battery life that way. So for long surgeries, you can actually prolong the battery life. And then all you have to do is say Scribe again, and it starts where you left off. If you use smart phrases, it orders it in a structured note for the op note or the procedure note. If you just start dictating just normal language, that's the prose part of the surgery. So it could look something like this, right? For example, you have patient John Doe, April 21st is yesterday. Pre-op diagnosis, severe calcific aortic stenosis. Post-op diagnosis is exactly the same. You have actually the pictures of exactly what the valve looks like. You can see how calcified it is, how stenotic it is. It doesn't open that well. And you have a picture of the new valve going in. And below that, it's not playing right now, and we won't play for the purpose of time, is an actual video clip. And this is an example clip of exactly what happened during the surgery. And you can imagine you could do this for almost all surgeries, and it becomes a very rich tool that you can refer back to patients, referring providers, primary care providers. So you get the point. So, where are we? So I think, like I said, we're about 60% done in building the smart phrases, the structured op note. Obviously, there's a lot of stuff left to do around HIPAA compliance, but given the stuff at BI and the Brigham, it's doable. Some alpha and beta testing for battery life and longer surgeries, shorter surgeries. But the key thing we want to do is actually do a feasibility and validation trial to actually look at what impact that this can have on the timeliness of dictations, the duration of dictation, and the completeness of the actual post-procedure node. And as far as next steps, as far as scale goes, doesn't really have to live with just the operating room. Think about how many elective procedures we do every day, or colonoscopies, cardiac catheterizations. There's a lot of other procedures you can apply to as well. So just to be, the credit is due, there's a very awesome team of students I'm working with. Actually, they happen to be in India, and I have how much time left? None. All right, so I'll spare the story, but after I can tell you a great story how I met these guys at the MIT Media Lab, and actually gave them my Google Glass, and we're working together for the last 3 weeks in building this whole software. Thanks.
One audience question.
All right.
One of the things related to information mapping, chunking, bringing information together that way. Have you worked with any specialists in that area?
I have not.
Look it up.
Interesting. All right. Awesome.
Thank you, Malik.
I appreciate it.
Hi, everybody. My name is Piyush Gupta. I'm an internal medicine resident at Brown University in the beautiful state of Rhode Island. I'm here to talk to you today about Glass on Call. Glass on Call, we're trying to create a more efficient social communication platform between patients, providers, and EMRs. And I swear to God, I did not know their products before I created the pitch. I didn't know anything about them. So here's a problem that I currently see with our current communication system in the hospital.
Here we go. Okay, now we're going to start on the next part of the procedure. Again, you may feel a little pressure. Okay, you're going to draw back a little bit. This is ridiculous. Nurse, can you come help me out?
Yeah, what do you need?
I need you to get this pager. I think this might be important.
All right.
Don't contaminate the field.
Okay, I'll grab
you need
the
to reach
pager
around.
right now. Okay. All right,
All right.
the pager.
What is it?
It looks like your patient down the hall, his potassium was 8.5. And then the second page says that they're actually about to start calling a code because he's going into torsades.
This is ridiculous. If only I'd been able to see that information when it first came in, I would have been able to give medications and prevent this from happening. Man, something needs to change.
So how many people are doctors? Raise your hand if you love your pager. Nobody. All right. So the current modalities for communication inside the hospital, we have the in-person communication, we have our pagers, we have our intercoms, and the brand new sexy bring your own device so we can add WhatsApp to it. But the problem with all of these solutions is that they're extremely inefficient for the caregivers. It's estimated that caregivers lose about an hour a day doing this, which leads to, I'll get to the numbers in a second. It's only allowing one-way communication, which we just saw. It's not hands-free. We're breaking our workflow, so if I'm focusing on a task, I have to look away at my pager, go do the second task, and then come back to my first task. There's a lack of automatic updates. It's estimated that this inefficiency is about $1 million per hospital system, about $5 billion for the entire industry. And there's multiple HIPAA violations for any of those communication modalities that I just listed. But most importantly, I think that this has been a recurring theme tonight, is that we're losing the human touch. We're looking more at our technology than our patients. We're breaking that beautiful social interaction that existed years ago. So now I can spend more time finishing my tasks. I can look at my pagers. I can look at my smartphone. I can look at my computer. So what am I proposing? Glass on Call. We'll be able to get automatic live patient updates. For example, if I ordered a stat blood draw, I'd be able to get the blood draw right to my face as soon as it comes back. I don't have to check the EMR anymore. I'd have visual paging. So I'm not just paging with text messages, but I'm now paging with photos, video, and when Google invents it, smells. It's hands-free communication, which I'm going to show you an example for in a second. We'd be able to prioritize messages because, as all care providers know, not all pages are created equal. What we'd be able to do is suppress messages, forward them to create maybe a to-do task list. We're able to forward messages to other care providers. We'll be able to set priorities for those high-value messages that we need to act on immediately. For hospital systems, this would be a great way to create an audit log of all of our pages to really analyze in-system communications. And lastly, we'll be able to give urgent orders, which I'd like to show you right now.
I'm inserting a needle into your back.
I'm not an
now,
actor.
So please try not to move. There's a needle in your spine right now.
See?
Oh, I'm getting a message. One of my patients down the hall, his heart rate's in the 160s. Okay, Glass, pull up the telestrip. I see that it's in rapid AFib. Okay, Glass, tell the nurse to give 10 milligrams of IV DILT. I know that the patient responded to DILT in the past. Okay, Glass, send a message to the nurse. I will be there in 5 minutes. Sorry, sir, I'm just finishing up. We'll be done in a minute.
So in this scenario, I know there's multiple HIPAA violations. Please disregard. This is just, I was talking out loud what I was saying so people that aren't in the medical field could understand my thought process. But if you just imagine for a second the use case scenario and expand that a little further. So what's the market look like? I know every single startup in the world will say that their product is for every single doctor, every single hospital facility, but I actually believe that this one would actually be for every single hospital facility. Because inefficiencies in workflow is a common problem from everyone. There's approximately 6,000 hospital systems, so more efficient workflow is estimated to be about $1 million of additional revenue per facility. The model will be subscription-based. It'll be the same price point as current pagers and be able to utilize in-house Wi-Fi instead of cell phone receptions.
Excellent presentation, Piyush. This is Karandeep. My question for you is, how do you decide what should actually show up immediately and what should get suppressed?
Sure. And okay, so, and I think that that's a problem that varies from every single specialty. For example, the plastic surgeon would have different requirements than the internal medicine physician. So what we need to do is that people would have the ability to create their preferences prior to using glass.
Thank you, Piyush.
Okay, thank you very much.
I'll just go ahead and introduce myself.
Take it away. The best for last.
Hello. I'm Austin Chang. I am an internal medicine resident at New York Presbyterian Hospital in New York City, but I'll be moving to Boston really soon to begin gastroenterology fellowship at Brigham and Women's. Yay. So first and foremost, thank you so much for this incredible opportunity. It's really a privilege to be here among so many innovative minds. So I'm here to introduce my Google Glass concept of procedure bank. So now I believe that practitioners, proceduralists, including gastroenterologists, surgeons, ophthalmologists, interventional radiologists, even pathologists who are performing autopsies, will turn to Google Glass as their first-line, day-to-day, hands-free communication device. But I don't think it has to stop there, obviously. It's not simply a substitute for our current mobile devices. The idea is that as an aspiring gastroenterologist, my mind went straight to the applications of Google Glass within the procedural setting. And not only because of its hands-free nature, but also because what matters most in executing a procedure is the perspective of the operator. And so what happens when the practitioner faces a difficult situation, a challenging case, complicated anatomy? Chances are others have faced a similar situation in the past, but now with Glass, unlike before, we can actually capture and share the vantage point of the operator. And as a result of social media as well, we can even discuss and learn from one another as well. So the idea of exchanging information and using, learning off of others' ideas isn't anything new. Consulting firms have been doing this for ages, and even medical journals have been publishing case reports regularly, and that's been an invaluable resource when it comes to rare medical conditions. And so this is where Procedure Bank comes in, because Google Glass can help film a procedure, and after the procedure, the video can be uploaded online to a procedure bank, whereby the idea is pretty simple, but up until now it's been difficult to execute because even with cell phone footage, by a bystander, you're not quite capturing the perspective of the operator. And so as a fan of YouTube and social media, this can be best compared to basically a YouTube model of a video library of procedures, and in essence, an organized and visual collection of case reports. And so when these videos become available, practitioners all around the world can learn from these procedures, can comment on, can critique, and can improve upon these procedures. And I don't only see this being used as a learning tool for teaching purposes, but also even during a procedure, practitioners can stream these videos live through their Google Glass and also allow that to help guide their procedure as well. So the bottom line is medicine is all about exchanging information based on the ideas created by others. And in doing so, we can help improve patient outcomes, cut healthcare costs, shorten hospitalizations, and but then the idea of procedure bank still has a long way to go. For instance, it's not very, when patients, in order to enhance patient participation, we need to ensure their privacy. But on the other hand, there's some outstanding questions. For instance, do procedures that have gone wrong, should they also belong in procedure bank? And so while these questions are being sorted out, let me remind you of the reasons why procedure bank is important. So first of all, it harnesses the unique sort of game-changing qualities that Google Glass can provide, where someone can take on the operator's perspective. And second of all, it can serve as, it can enhance medical education by being a brand new visual medical resource. Number three, it fosters communication among practitioners where they can discuss and improve upon current procedures and standards of practice. Number four, it impacts patient care. It can save healthcare dollars. And number five, it's actually doable. We have the YouTube model already. We have basically an interface that is widely accepted, and we just need to tweak it and tailor it to our needs. So once again, thank you so much for this opportunity. I really appreciate it. And if you want to contact me with ideas, my Twitter handle is on the program, and you can also find me on MedStro. So thank you very much.